everyone, this is Rebecca Salauda from Tosa Together. I'm happy to welcome you to Tosa Talks, Building a Diverse, Thriving Community, an ongoing Facebook Live series proudly sponsored by our generous friends at Bostic. Tosa Talks features 3 monthly presentations featuring local neighbors, community leaders, and issue experts. This ongoing 3-track series is structured to provide learning opportunities and foster meaningful discussions around racial and social justice issues, as well as help build an inclusive anti-racist community. We are excited to be joined by Theresa Jones, Vice President of Inclusion, Diversity, and Equity for tonight's Tosa Talks presentation, The Racial Impact on Healthcare. The Equity and Inclusion Issue presentation track streams live at 7 p.m. on the 3rd Wednesday of each month. Please also join us for the Personal Stories track on the 2nd Tuesday of each month and the Government and Organizations track on the 3rd Wednesdays. Presentations are recorded and available on this Facebook page or on the Tosa Together YouTube channel. We welcome and encourage you to take part in the question and answer session tonight. Please add your questions into Facebook comments section during the presentation. So let's get started. It is my pleasure to introduce Kevin O'Brien, who will introduce tonight's featured speaker.
Thank you, Rebecca, and good evening and hello, everybody. My name is Kevin O'Brien, and it's my distinct pleasure to welcome Theresa Jones. As Rebecca mentioned, she's Vice President of Inclusion, Diversity, and Equity at Children's Hospital of Wisconsin. In her role as Vice President, Theresa leads the development of the Inclusion, Diversity, and Equity Strategic Plan and its alignment across all parts of a very large health system. She advises senior staff on ways to address, track, and measure improvements of inequities while promoting opportunities for the health system's workforce, culture, health equity, and the community. Theresa brings over 15 years of experience from an array of leadership roles in local business, educational, and health system positions. She received her degree in management and communication from Concordia University and a Master of Science in Organizational and Leadership Development from Norwich University. Theresa currently lives in Brown Deer, and in addition to her service at Children's Hospital, she is active in organizations throughout the Milwaukee area, particularly those focused on diversity and cultural competence. She's often featured as a panelist and presenter at conferences and has been a board member in a variety of Wisconsin organizations. So please welcome Theresa Jones of Tosa Talks, someone who's obviously very busy, and we appreciate your taking your time on this Wednesday evening with us.
Mm-hmm. Well, thank you, Kevin, and thank you all for tuning in tonight to talk about a very timely issue, which is racial and ethnic disparities. We're going to talk broadly about racial and ethnic disparities, but also hone in on one primary underrepresented group, which is Black individuals that have had much more disparities really magnified because of COVID. So we're going to spend some time talking about that as well. I think we're pulling that PowerPoint up, so if we could go right to slide 2, that would be great. So as we are looking at our areas of focus for tonight, we're going to start out by giving you some key definitions to help frame our work. We'll talk about racism as a public health crisis as well, what that means. We'll talk about key influences that occurred in this year of pandemic and what that looks like. We want to talk about what disparities exist that we can speak of specific to the African American population. We'll talk about this whole issue of equality versus equity and what that means and what that really has meant for healthcare systems, because we have to do some shifting around our mindset around those two things. And then, of course, most important, which is how you can help. You can go to the next slide. So when we think about this year, which is certainly an unparalleled year, one of the things that really had significant impact on health disparities is racism. And so certainly this has been going on for many years. It is not something that is new, but certainly I think the visual of seeing someone die directly at the hands of police really brought about a cry from multiple communities, actually across the world, that we needed to really address racism. And so this work has catapulted the work of health equity and addressing disparities into the forefront. And so we'll be talking a lot about that as we go forward in this presentation. So we can go to the next slide. So as we move through the discussion, we're going to talk about these key definitions that I want you to be familiar with, and really important that you understand them because I'll reference them throughout. So let's take a look at those. And the first would be racism. And so many times people define racism very differently, but it can be defined as either prejudice or discrimination that's really directed at a person or people on the basis of their membership of a particular either racial or ethnic group. Next slide. When we also kind of think further, you'll hear other terms like social determinants of health. And social determinants of health are those conditions in which we are born in, that we live in, that we learn, we work, we play, we worship, and age that really have some impact for health, our functioning, and our quality of life. And so we'll talk more about examples of social determinants of health, but that is the official definition. Next slide. And then important is institutional racism versus structural racism. So when we think about institutional racism, we might be thinking about either an unfair policy or practice specific to an organization, some type of discriminatory treatment or inequitable opportunities. It exists in employment, it exists in governmental agencies, and sometimes in our social services. As opposed to structural racism, much more broader across society. It could be in how individuals of color are portrayed. It could be in just basic policies that have been in place for many years that have really impacted underrepresented groups. So we'll talk about the distinction as we again go through our presentation. Next slide. And then lastly, disparities. Being basic disparity is a condition of being unequal, or if a major gap, it could be considered unfair. Then when we apply health to that lens, it's a higher burden of illness or mortality experienced by one group relative to another. And then adding on health care on top of that it's a difference between groups, might be in health insurance coverage or access to, use of care, and the type of care or quality of care. Next slide. And then lastly, health equity. This is really what we're trying to achieve in every healthcare system, that everyone would have a fair and just opportunity to be healthy. We've adopted at Children's the Robert Wood Johnson Foundation definition, because that's really our goal, is that everyone has that fair opportunity to be healthy. But there are some things that impact that we have to come to understand and then begin to really work together to address. So next slide. So when we talk about racism as a public health crisis, many people say, well, what does that really mean? And it was not just Milwaukee. Milwaukee was one of the early adopters, but we know that there have been several major cities across the country that have really identified racism as a public health crisis. What does that look like? It means that racism is a major factor, and here in Milwaukee, it's a major factor for our Black or African American community. It becomes more of a societal issue when you think about it in that kind of context. And it's because of all the disparities that this particular population has experienced that really makes it rise to a public health crisis level. Next slide. So let's take a look at some of the issues that contribute to that. The Black median household income in Milwaukee, which is adjusted for inflation, has declined 30% since 1979. Here in Milwaukee, it has the lowest Black median household income, adjusted for either metropolitan area or cost of living differences, of the nation's 50th largest cities. And the income of the median Black household in Milwaukee is 42% of that of an individual that might be white or non-Hispanic. So as you can see, these things all attribute to the Black poverty level being at 33.4%, which is the highest poverty level in any of the nation's largest metropolitan areas. Next slide. When we think about other factors and how that contributes to racism being declared a public health crisis last year, we look at the incarceration rates. Milwaukee registered the third highest rate of Black incarceration in state prisons among the 50 largest metropolitan cities. We briefly talked about poverty just a few minutes ago, but we know that wealth is really attributed many times to home ownership. And Milwaukee has the second lowest Black home ownership rate among the nation's largest metropolitan areas, with Minneapolis being one lower. Employment. 2/3 of our Black males between the ages of 25 and 54 were employed in Milwaukee. This is between 2016 and 2018. That's the third lowest rate among large metropolitan areas. Management. Blacks are severely underrepresented in management occupations in Milwaukee in proportion to their weight in the labor force. So all areas that we have been really taking a look at very seriously, and why Milwaukee is starting to be really, or has been declared a public health crisis. I've said racism being declared a public health crisis. Next slide. So we talked about income a few minutes ago, but let's take a look at education. A white high school dropout is over twice as likely to be employed in Milwaukee as a Black dropout. White high school dropouts post a higher employment rate than Black high school graduates in Milwaukee. Our schools. Black school children in Metro Milwaukee are as likely to attend an intensely segregated school, and a school which we say is enrollment is over 90% minorities. The comparison, and we'll talk more about this report that really supports this, related it back to 1965. So definitely not progress being made there. And for many years, infant mortality, Black infant mortality rates, teen pregnancy rates, and low birth rates for Milwaukee rank among the worst for Black communities in the nation's 50 largest metro areas. Next slide. So when we think about racism as a public health issue, all of these issues, whether it's employment or education, the criminal justice impact, poverty reduction, housing, the list goes on, that all of these things cause stress and have really caused us to have a really major problem in the Black community. This was related back to the 60s. And so the report that this is coming from, that you can really learn more about it, is The State of Black Milwaukee, A National Perspective by Mark Levine from UWM. And that report was released back in July 2020. I just took excerpts from that to really share some stats with you. It has many more, but I think it gives you really a good sense of the impact of racism and the impact of disparities on communities of color, and in particular here in Milwaukee for the African American population as well. Next slide. So 2020 has been a challenging year for all of us. There have been some key influencers and impact upon individuals of color that I think we should highlight. So let's take a look at the next slide. So we kind of want to make sense of it all. And I know earlier this year, after the death of George Floyd, many in our organization were asking questions about why is all this occurring? So let's think about it. There were already several disparities happening in many communities. Then COVID-19 came along in March, definitely unexpected. And so that exacerbated those disparities even more. The disparities we're talking about is lack of food, lack of jobs, lack of income, and the list goes on. That increased negative impact to community of colors, coupled with ongoing acts of racist behavior that were demonstrated by law enforcement and made very visible across the US, really it exploded into protests and riots across the country and actually across the world. Those social determinants of health that were already problematic really got exacerbated as this went on. And not that we would condone violence in any way, but we were ripe for that eruption. Why? Because of the stress of all that's occurring, and it is still going on. We're not out of that. So when we try to make sense of it all of those things added up to the difficulties that we're seeing, and it really exacerbated the impact for individuals of color in many of our zip codes throughout the Milwaukee and surrounding area neighborhoods. Next slide. So what key impacts were as a result of COVID? And I've touched on some of these already. Certainly the loss of employment and insurance. Still, many people today unable to get unemployment insurance because of the backlog. Food insecurity, a huge area. Think about it. You've got kids at home all day. In many cases, some families were not being responsible and having to pay for any food, and now you've got kids home all day. So definitely a huge gap there and a need. Lack of transportation getting to and from work. Several generations in one family living under the same roof. You know, children being left at home alone during the day due to parents working. We've seen a rise, and even at Children's, I was just speaking to a physician, I believe it was yesterday or the day before, saying the number of children that have really suffered from gun violence because all family members are either at home all of the time, or kids have had access to guns because there's not parents in the home as well. And then lack of access to technology. Children that should be getting educated virtually are not. And so they're just at home. And then, of course, housing. So many impacts. There's probably more that I could list here, but some of the more common ones that we certainly have been working to try to address at Children's. Next slide. So what disparities really exist? We're talking about health and healthcare disparities. What disparities really exist? Let's take a look at that. Go to the next slide. So when we think about social determinants of health and we think about the impact on health outcomes, this slide really gives you a sense of how this really all comes together. So when you think about the individual and what they may engage in from their own health behaviors to looking at their access to care and the quality of care that they may receive or not receive in some instances, along with social and economic factors like education and employment and income, like we were just speaking about, safety as well. And then the physical environment that people are living in, and we just talked about that being a safety issue and potentially violence as well. All those things come together to be health factors. So when we think about healthcare systems, the programs and policies that we may have that may dictate how healthcare is delivered, when it's delivered, how it's delivered, the time of day that it's delivered, coupled with all those health factors, have impact on health outcomes. They impact a person's, certainly their quality of life, and they impact the length of life. So let's maybe think about an example. So if I'm an individual that right now is struggling with employment and income, that may also have children at home, and so we're struggling with funds to support food, and I'm in a situation where I'm in a violent or a very unsafe environment, I may be struggling to be able to get in for healthcare or get that child in for healthcare. And so if we have a policy on the fact that if you're late for your appointment, over 2 or 3 times, and that is the cutoff at that point, that is going to impact because now I can't get seen or get my child seen for healthcare. So it causes us to have to really take a look at our policies and our programs to say, are we providing equal services? And we're going to talk about that in a few minutes. Or can we provide services that are equitable? Can we look at our hours of service to be more accommodating to our families? How will that work? And how can we really help to improve the health outcomes for patients and families? That's just one example, but all of those factors impact an individual. And as a healthcare system, we have to try to balance that and work at ways to be more creative in how we deliver care as well. So next slide. So let's look at disparities, and we've talked a little bit about that. So when we talk about minority communities, in particular the African American community, we know that certainly high blood pressure, diabetes, poor immune systems, heart disease, stroke, cancer, all very chronic diseases, but they're really exacerbated by the stress that's been going on around poverty, racism, and the list can go on and on. So those are those primary disease states that are impacting communities of color that have now been exacerbated by racism primarily, along with all the other factors as well. Next slide. So this slide was actually one that was pulled from a while ago. But what I want to talk about here is the importance of us really always looking at data by race and ethnicity. And if you remember very early when we were reporting rates of COVID positive tests, they were really shown in a way that showed the impact to different communities. If you notice now in the media, that's not been shown as much. But if you were to go out to the Milwaukee Health Department's site, you will see the distribution. This is an older one because obviously we know those positive test rates are much higher now. But we always have to look at this data stratified by race and ethnicity, because when we put it all together, it really doesn't show the disparate impact. So everything that we do from a healthcare system, we are now trying to move in the direction of looking at what is that impact to certain communities. And if you go to the next slide, not only is it important for us to look at the disparate impact, but the reasons why. And so we were just talking about some of those, generational lack of access to healthcare, minorities being overrepresented in essential jobs. So when we think about many of the essential worker jobs, things like nursing assistants in particular, all of those frontline types of food service workers, all of those frontline jobs that people had to go to work. So they had to make decisions. Initially, they might not have had any paid sick leave. They might only be working part-time and not have had paid sick leave. They don't have a lot of freedom in terms of policies. We talked about the multiple generations living under the same roof, and that being occurring because it's cheaper. Some families just live in that way because they have all those generations in one home. And then, of course, just living in close quarters, close populations living together in neighborhoods, and the national slow acceptance of the threat of COVID. So all of these things come together to have a disparate impact upon certain populations. Next slide. So let's talk about equity versus equality. There is a difference. And so as we talk about equity and equality, the video that we're going to be queuing up will give an initial explanation, and then we'll come back together to talk a little bit more about those differences. But for many years, health systems provided systems in an equal manner, that it was important to really deliver care, to give the same level of care to every person. That was what we strove to do. But we're in a different time now where equity is more important. And so let's watch this video that will talk a little bit about the differences between equity and equality. And while we're queuing that up, Kevin, I don't know if we have any questions that have come in.
Not yet, but it's a great time to encourage questions. I know we have people participating, so please feel free to put in chat, about any questions that you might have. Rebecca, I'm not hearing any volume.
Yeah, I was going to say the same thing as well.
Did you see the video, just not hear it?
Yes.
Yes.
Okay, because I was on mute, so I will go back to the beginning.
These days, we hear a lot of people
Better?
using the word
Better.
Good deal.
really mean. It's not quite the same as equality, which means everybody gets treated the same. Equity is about fairness. It means that everybody gets what they need based on their own situation, because we're not all the same. The difference between equality and equity is important. It's part of the reason the United States spends more on healthcare per person than any other advanced nation and has much poorer health. It's important to remember that a person's health depends on many factors, things like their environment, schools, and workplaces, to name a few. We call these social determinants of health, like clean drinking water for children and easy access to fresh food. We can follow the lead of communities like Columbia Gorge in Washington and Oregon, where businesses, doctors, and farmers tackled the local hunger problem with the Veggie RX voucher program. And the New Jersey Partnership for Healthy Kids is bringing down high rates of obesity in underserved communities. We should be inspired by these local efforts and remember that health equity is all about making things better for all of us. When everyone's healthy, everyone benefits.
And thank you for that. So as we think about equity versus equality, it's important for us to realize that we can no longer provide service to individuals in healthcare in just an equal manner. It does not meet the needs. And so in that video, you saw them use the example of the smaller young person that was riding the bike, the same size bike as everyone else. Obviously, she wasn't able to go. Or you can think about a person with disability who might be able to ride a bike if they had one that had accommodations for them. That is more equity. So we have to start really thinking about delivering services and providing care from a equity manner versus a equality manner. And that is a shift in mindset, because for so long, everyone has been focused on delivering care and service, giving the same service to every person that comes through our door. That's been the goal. But we've had to shift our mindset and say, what's equitable? That will really help people to achieve their best health outcomes. Next slide. So it does require taking an approach, which I mentioned earlier, which is really stratifying our patient outcome data by race, by ethnicity, by gender, language, and other diversity dimensions to really reveal the disparities. But it's not important just to be able to stratify that patient outcome data, but we've got to talk with the populations we serve to really understand why there is a gap. Creating and implementing interventions that work to close that gap for that population is what we have to do. But you can't really just create an intervention without understanding what the real issues are. And that in itself can be a challenge. Many minority communities do not trust healthcare. Why is that? Historically, there have been a lot of experiments done on individuals of color that have really caused, wound up people winding up dying as a result. And so healthcare isn't a trusted profession. And so that building of trust takes time and being able to really get in and understand why there is a disparity. Let me give you an example. This example is not one from Children's Hospital, but at a former healthcare system, we saw a very high incidence of diabetes among African-American women. And so as we looked at their A1C levels, we really were trying to understand, why is that occurring? So what we did, we actually had their nurse practitioner invite them in for a meeting. They came in and talked with her. Some of them did, some of them didn't. But we decided to, in partnership with the Robert Wood Johnson Foundation, and sent them to come and talk to us, because who wants to really come in and talk about diabetes? That's not an exciting topic. So we felt like maybe if there was a way to incent people, they would come. So we provided a healthy meal and actually did some focus groups. We learned so much in those focus groups by really getting them to talk about the why. And what we learned was, first, many of them didn't understand what diabetes was. And in the African-American community, some people called it sugar. Some people said, you're going to die with something. Other people said, oh, it's not a real big deal. Everybody in my family has had it. So there were so many different perceptions of what diabetes was and the level of seriousness that we really started to get our eyes opened a lot about what we needed to do. We talked about preparing food. And so, historically, your mom, your grandma, whoever it is, may teach you how to cook. Well, how many of them had learned to prepare meals were really not healthy? They needed to understand you could cook those same meals, but you had to prepare them differently and to learn techniques to be able to do that. Or, for example, taking insulin. Many of them said, I have to make a decision. I just barely have enough to make my ends meet and to be able to pay rent. But now I've got to try to make a decision on how much I can actually spend on medication. So there are times where I have to make decisions to pay rent and get food and not purchase my medication. So I share these examples. The list could go on, but that trust that we were able to build with that population to really understand the why really helped us understand the interventions that we needed to do. We started offering free cooking classes just to educate, and we found they began to come and to learn. We gave them recipe books, and the list went on to understand why. We started doing more home visits to their homes to talk to them in their environment. So all things that normally we would say, we're going to provide equal services to everyone. No, we had to really dig a little deeper and come up with interventions that would help this population improve their health. And then we gradually started seeing that improvement in compliance, coming to their appointments. They felt their healthcare system cared about them and that they were learning new techniques on how to eat and how to prepare food, along with working with some of the pharmaceutical companies to get discount coupons on prescriptions. So it took all of that, which is very different. We wouldn't think you would have to do those things, but if we want improved health outcomes, we have to get underneath the reasons that those issues are occurring and go that extra mile to make sure that we're providing care in an equitable way versus an equal way. So I just wanted to take a little time to give you that example on how it really does require us to get underneath why that data is looking that way and what we can do to address it as well. We have to also, we somewhat do trial and error. And what I mean by that is we don't always know what interventions are going to work. So you will try certain interventions like I just described, then measure the impact. From there, whether or not they have worked, you might have to do some other things. It requires tweaking our approach based upon the needs of the patient and the family. It may also require examining our policies and our procedures. I gave you the example of a late policy, where someone might have taken the bus to get there and the bus is late. They get there and they now have been late 3 times. We won't see them. So we've got to say, is that policy a good policy, or do we need to allow some more flexibility in how closely we schedule patients? So in the event that someone is late, we can really accommodate that person that might be arriving late. So no longer can we do a one-size-fits-all approach. We have to be able to really look at individual situations and develop interventions that will help not only that person, but help the community as a whole. So I hope that helps you understand our need to shift from looking at things from an equality standpoint to an equity standpoint.
Theresa, no questions yet, but to me, as I'm listening, the equity versus equality difference seems to parallel, like on an individual level, how we have to shift our focus, especially as white folks, around what our intent is to what our impact is. And that's similar at a system level. Our intent is to deliver equal care to everybody, right?
It is.
Proportionate impact, then we have to take that seriously and think more about how can we have a different impact.
Absolutely. And it's a new way of thinking, Kevin, to be very honest. And it takes a while to get underneath it. And so what I am finding in my work, it's my job to help be able to bring this kind of information to the forefront, that we use data at Children's to be able to really get underneath it. And we look at it from multiple different lenses to help expose it so that we can really help educate people and get underneath what's occurring so we can really work to improve that gap as well. Shorten the gap as well.
All right, we do have a question if you could take one right now. Question is, as a white ally, is there anything that people who don't work directly in the healthcare system do that could help make healthcare more equitable for people of color?
You know what? I'm going to ask if we could hold that question because, yeah, there are a lot of things, and we're going to actually talk about some of those things at the end of the presentation. But absolutely, this one is focused on healthcare, but there are lots of things that we can do in our daily lives. And so, for example, I gave you the issue of food insecurity. That's a huge issue right now. And sometimes we can't relate to that because we are all very blessed to be able to have access and have income. And so sometimes certain people can't really relate to that. But let me give you an example of a need and how it was addressed. And I just shared this with Kevin a little earlier today. So for example, in the Central City, I belong to a church, Park Lawn Assembly of God, right in the Sherman Park area. Huge area that's been impacted by COVID, huge area that has just been impacted for a long time. If you might remember, some of the rioting back in 2016 occurred in that area. And so our church partnered with another organization and actually has formed a food kitchen, commercial kitchen, right in that community. Why? Because we wanted to really provide opportunities for employment. And the focus is because many entrepreneurs, many caterers, many food truck owners cannot afford to, when they start their business, can't afford to actually have a commercial kitchen that they actually have prepare their food in. But now to have a license, you have to do that. So with that, Upstart Kitchen was formed. But with COVID, many of those food entrepreneurs found that they really couldn't actually do their business. But what they did notice was there was a huge food insecurity issue in that community. So they came together and with some donations, not only from the church, but from the community, have really put together an opportunity to prepare meals and be able to give them out to families in need. The food is prepared, it is frozen, and then it is delivered to a couple of churches and some other organizations that help us distribute the meals. So when we think about things that we can do and how we can look at things, there are opportunities to feed into healthcare. And food insecurity is a huge issue that crosses all organizations as well. You can give to those organizations. You can volunteer at those organizations if you feel comfortable doing that. But that is a huge issue. You can give groceries to organizations that are providing food. It's a great way to help healthcare by helping feed families. And we'll talk more about that in just a few minutes. So thank you for that question. I thought I saw another question, Kevin, that came in. Maybe I missed it.
Yeah, there's a couple, one's similar and we can hold on that one, but the one that's really tied to what you're talking about is what obligation are health systems under to ensure that they are providing equitable health care? Is this a voluntary effort on the part of healthcare systems, or are there standards that must be met in this area?
Well, I would tell you, I think when we talk about looking at health outcomes, I think initially in most organizations are concerned. Yes, there are some standards in place as well that certainly wants us to show certain levels of outcomes for patients. But I think when we think about the populations that we serve, and I can only speak for children's, but even I can, to be honest, I could actually speak for my former employer as well. When you serve large populations of minority employees, many of which may be on Medicare or Medicaid, clearly we're trying to look at improving those patient outcomes, not only because of the funding that comes with it, but because that's who we're serving and we want to have good patient outcomes. So it's a combination of both. But I think taking this deeper dive and looking at patient outcomes, stratifying them by race and trying to get underneath that, that's all voluntary because we're really trying to understand what are those outcomes and what can we do to really help improve the health of our patients and our families. So it is a combination of both. Yes, there's some regulations in there, but I think most organizations are just concerned about ensuring that their patients are healthy. And that's what's driving us to really get underneath the data so that we can figure out what's going on. So I hope that helps a little bit. So let's kind of dig a little deeper and take a look. I think we're ready to go to some examples. And let's pull that slide up. So wanted to get your thoughts about these. And these are just common examples. So a 65-year-old grandmother is diabetic. She frequently arrives late to appointments. She's not compliant with her insulin regimen. Her A1C levels are all out of control, and she doesn't have a healthy diet. What assumptions might you be making about this grandmother? And then let's think about what issues may be impacting her compliance. And then how could we work to get better compliance on her part? Be interested just to see your thoughts if you want to put that in chat as well. So what are the assumptions that we're making about this particular grandmother? Anybody would like to share when you just kind of see that data? What do we assume? Maybe she can't get to her appointments because she doesn't have a car and has to take the bus. She's not compliant with her insulin regimen. Maybe she doesn't know how to give herself a shot or is uncomfortable giving herself a shot. Doesn't maintain a healthy diet. Like I mentioned to you from a former employer, maybe she doesn't understand what a healthy diet is, or maybe she only has corner stores in her neighborhood and doesn't have transportation to get to other stores. Another one I see in the chat box, she doesn't know how to control her blood sugar. Very good. All assumptions. Any others?
Well, I'm a family therapist, so I think about how she might have, be cooking for her family. And if she changes her diet, it means everybody might have to change her diet, or it's hard for her to eat something different than everybody else is eating. And so that makes sticking to a certain diet harder.
Yes. Oh, it does. Absolutely. And, you think about, if we talked about, remember, some of the families that have multiple generations under the same roof, those children probably don't want to eat that healthy diet that she is eating as well. So let's just be real about it. She's got a hard, and she's probably been preparing meals the same way for many years. And so trying to help someone change the method that they use. So those are all assumptions and could be impacting her compliance. Based on some of the things that I've shared tonight, how should we work with her to get better compliance? What could we do?
Well, I'll jump in while people are thinking. I would say just what you did, I think, having us reflect on the assumptions, because it's easy to pass judgment and say, she doesn't care, she's non-compliant, just labeling or things like that. So just taking a pause to really consider what all the possibilities might be is a place to start.
Yes, absolutely. Absolutely. And sometimes we think they are big things that we have to do. But as I told you in the conversation that we had with those African-American women, some of them were very simple. It was explaining what diabetes is in ways that they could really understand and using language that they could understand. You would say diabetes, you know what you're talking about, but you say sugar, we got it. We know what that means as well. I say sitting down and making a menu. That's an excellent example of saying, or giving that recipe book. The American Heart Association has a wonderful soul food cookbook that gives lots of recipes prepared in a healthy way. Looking and finding there are resources out there that could help her learn how to prepare those same meals in a very healthy way as well. Other thoughts? What about the medication? Anything that we could do around that piece?
Just taking the time to ask her what gets in her way.
What gets in the way of you taking that and understanding what that means, and asking the same question. Why is she arriving late? Is she perhaps waiting on a family member who might be working somewhere else and having to come and pick her up? What does that look like? Or does she have to take the bus? If the bus doesn't come on time, she's not able to be on time. So I shared this example again to say it takes that digging deeper to understand and getting to know our patients and to be comfortable to ask the questions, and also to build the trust such that we can get at what those really issues are and come up with a good plan of care for this person as well. Let's take a look at the next example. So, an infant requires 24/7 hospitalization. The mom calls a unit to check on the child, but has to work and take care of one other child. So she's unable to come to the hospital during the day when the child is actually getting a lot of the cares. Now the child is being discharged, but mom is unable to come and pick up the child until she gets off work. And she doesn't get off from work until 8 p.m. What assumptions could be made in this situation? And these are real situations, by the way, that occur. So what assumptions could be made about this particular situation? While you're thinking, one that I would share would be that the mom doesn't care about the child. That's usually the huge one. She can't come during the day, and now the child's been here for several days. She only can come at night. She's only spending an hour or two with her child. She really doesn't care about that child. And now that child is being discharged, and now she can't even come and pick up the child. What could we do to demonstrate a more equitable approach to help this mom? Well, when we think about what we could do, there's lots of possibilities. Asking her why she can't come during the day, a real basic one. Could we do it? Mom wants the hospital to be a daycare. No, well, that is one perspective as well. But I would tell you that these are real situations, especially with many of the moms that we might see. And what usually is the case is they really are working during the day. They don't have any other individuals to be able to come. So telehealth could work really, really well, that we could actually be able to do a visit with the mom to tell her what's going on with her child and be able to explain those things, right, so we can talk with her directly. Another one is that not having these set times when a patient has to be discharged, but saying, can we discharge exactly a time to meet her needs? That's exactly it as well. That clearly this mom can't get there till 8, so why can't we discharge that child at 8? So being more flexible in our policies, not having an equal across the board policy that says every child has to be discharged by 11 o'clock, but being able to be somewhat flexible with that and looking at other ways to connect with mom. So again, this is an example of equal policies across the board and how they could become more equitable. And let's look at our next example. So this is an elderly patient. She's been assigned to a community navigator. A community navigator is someone who may visit a patient's home. And this particular patient has asthma. Frequently, they call the patient, they don't get an answer. They've gone to her home. The patient is frequently not home. She's a no-show for a lot of her appointments. What assumptions might be made relative to this particular patient?
See, Theresa, as you pose that question about assumptions, would you like people to start with some of common or some of the potentially negative assumptions people might make? Or?
Yeah, either way, I think is helpful because there's lots of assumptions that could be made. Mm-hmm. I'll share one, and it's a big one, that that particular elderly person may be homeless. Homelessness shows up a lot. So that may be the last known address that she was at, but this person may, and more likely than not, probably could be very homeless. And so that's why we now ask about social determinants of health in many of our screenings of patients, because that person could be homeless. And so we're assuming that she's living there. That's her last known address, but she's really not living there any longer as well. What else?
Yeah, and there was an example given, and this would be one of those potentially negative judgments some people might make of doesn't care about the community navigator's time. A person might feel like, well, they don't care, I don't care, kind of thing.
That's very true. That is very, very true. Definitely an assumption that could be made as well. Absolutely. Could be. Maybe she doesn't hear well. Maybe she's not hearing them when they come to the home as well. Could be another one. Again, transportation could be an issue for her as well.
She could be scared.
Could be afraid. Absolutely. She's an elderly person. Very much so as well. So we have to get underneath. So when we do see, many times it starts with the calls. And if we see patients are not responding that way, then we will send a community navigator out to the person's home as well, and try to get underneath what really is occurring. But homelessness is a very real issue. Poverty is a very real issue. It shows up in healthcare. And so we can't forget to think about those things when we're trying to ascertain what are the reasons that someone may not be accessing healthcare the way that they should. So, I think we've talked about the fact that we could send someone directly to the home. We've done that. We try as much as we can to use multiple ways to access family members to find out what's going on with that particular, patient as well. So we try to get underneath all of those different options so that we can still find out what's happening, be able to make that connection as well. But we do find that many families we do see are homeless. And so trying to trace that down can sometimes be a challenge as well. And did I see another question, Kevin?
Yeah, well, it's a comment that just piggybacks exactly what you said. So if she's homeless, some of those other bigger social determinants of health might be a bigger priority. Like, she may not feel like she has time to worry about her asthma if she's worried about whether she's going to have a place to live in next month.
Absolutely. Very real priorities. Definitely. So someone asked earlier about things that we can do, and there's multiple things that we can do, and we're talking about what we as people can do. And so I want to go to the next slide because we talk a little bit about what health systems can do. We talk about what individuals can do and how we can help close the gaps on disparities. So you can go to the next slide. So at the individual level, we just talked about it. No matter whether you're in healthcare or not, whatever data that you're looking at about situations, ask for it to be stratified by some of these diversity dimensions. It'll help you understand the differences or the disparities, and then help you get on the track to address any of those gaps. If you're a business owner and definitely have opportunity to hire, make sure you're recruiting and marketing your positions broadly and that your staff is diverse, providing opportunities for youth. I just shared with you a lot of data about employment and unemployment for minority groups. There's an opportunity if you're a business owner to be able to help with that as well. If you serve on a board, what elements of diversity are missing from your board? If you want a broader lens about what's occurring, you want diversity represented there. So certainly invite that diversity and recruit it to any board you might be on. Sometimes it may be just as simple as starting conversations with your neighbors. Reach out to others that are really different from you so you can learn about other cultures. I find many people, and I certainly with bringing racism to the forefront, many people are afraid to actually have conversations with their neighbors. So we're trying to invite people, talk with your neighbors, reach out to others that are different than you are, and you may find you have a lot more in common and learn more about their culture. And then assumptions, we say, try not to make them. Talk with others to understand what their situation is, and then try to help where you can. And then we just talked about social determinants of health. If you have an opportunity and can give, we certainly say give. If you can volunteer, especially with COVID right now, and you feel comfortable, certainly volunteer, and you can help to work to address employment, food insecurity, education, all of those different social determinants of health. Many of us belong to churches, and churches are doing a lot of outreach. Again, be comfortable and be safe relative to COVID. but find ways. Again, I can't stress enough, food insecurity is such a huge issue. So if there's an opportunity to give and connect with organizations that are trying to help, that is a huge way that as an individual you can help. Let's talk about what they're doing at the county and the healthcare system level. I think that's the next slide. So the county has made a commitment to addressing racial disparities. They're looking at their policies and their procedure to make really sure that racial equity is at the core element of the county. They're working on inclusion, identifying specific activities to increase diversity. They're incorporating both inclusion and equity and offering training to expand employees' understanding of how racism really has an impact for people. They're looking at policies that will improve health for communities of color. And then, of course, they're encouraging other local, state, and national organizations to really recognize racism as a public health crisis. That fact, that last one really has catapulted racism into a major area of social determinant of health, and it's really caused everyone to start really digging deep to say, what can we do? So while it's a difficult situation, there's a lot of positive coming out of it because people are starting to really take a look at things from a racial lens, and it's really helping to expose some of those disparities. Our next slide.
And Theresa, I think we're coming close to 8. I'm amazed at how fast that time went.
Yes, so we're
gone.
really wrapping up. These are the last things that healthcare systems can do, and we've talked about many of those, so I won't go into the detail, but definitely know that many healthcare systems, just like children's, is digging deeper and really trying to find ways that we can help our staff and help our patients and families to achieve better outcomes. So Kevin, I think that is it. That concludes things for me. It's certainly been a pleasure to share some of that information. We could talk about this subject for a long time, but definitely appreciate the opportunity to share these thoughts with you.
Yeah, absolutely. Again, I'm amazed how fast that time went, and really appreciate your time that you took with us tonight, Theresa. And put a quick plug in for anyone who is not yet connected to Tosa Together. That's a clear and obvious way that you can get involved in our local community to breaking down barriers for people to have access to good housing, access to schools, access to good health care. But again, please join me in thanking Theresa Jones from Children's Hospital of Wisconsin for joining us tonight. We really appreciate you sharing your thoughts and experiences and those great examples with us. Also, a big thank you to our Facebook Live audience for your time, as well as your comments and engaging questions. We hope you found this presentation enlightening and inspiring. Please plan on joining Tosa Talks next Thursday, October 29th, when our guests will be representative from the Wauwatosa Health Department, and they'll help us take a deeper look at public health through a racial justice lens. Feel free to reach out to Tosa Together anytime through our Facebook page, our website, or by emailing us at tosatogether@gmail.com. This is Kevin O'Brien from Tosa Together, and it's been my pleasure to be here with Theresa Jones. Thank you again, as well as with all of you tonight. Thanks again for being part of Tosa Talks and our mutual effort to build a diverse, thriving community. Good night.
Thank you.